A very warm welcome to this seminar. We have three excellent speakers today who I will introduce in turn. They will each speak for 10 minutes and then there's a 5-minute Q&A afterwards. Please put your questions in the chat and we will do our best to group them. If we don't get through all the questions, the speaker may be able to address some of them either in the webinar whilst the next talk is going on or afterwards. So don't be shy, put any questions you have in the Q&A box for us to pick up. So a little bit about NIHR ARCs. There are a network of 15 applied research centres across the country. They're funded by the National Institute of Health Research, Health and Care Research, as is now, and they do applied research that's of direct patient benefit or direct benefit to the health services. So without further ado, I'm going to invite our first speaker, Dr. Ruth Plackett. It's my very great pleasure to hear this presentation because it's a subject that's really important and very close to the work that my team does. So Ruth is a research fellow at University College London, and she's working on a 3 schools mental health programme fellowship. So there's the School for Public Health, the School for Primary Care and the School for Social Care. And they, in order to stimulate interdisciplinary research, they have these fellowships. So congratulations, Ruth, on getting them because they're highly competitive. And Ruth is going to talk to us about the longitudinal impact of social media use on children and young people. So Ruth, over to you.
Thank you. And thanks for the introduction. So yeah, I'm going to tell you about some work I was doing looking at this kind of longitudinal relationship between social media use and adolescent mental health, using findings from the UK longitudinal household study, which is also known as Understanding Society. So to give a bit of context about why we're interested in this particular topic and why I chose to research it, as I'm sure many of you are aware, young people's mental health problems have been increasing really over the past decade, and since 2017, we've seen a real sharp increase in probable mental health disorders for young people. So it's clearly, a rising issue, and we've seen an increased sort of demand on the health services as well for this. And at the same time, we all know that social media use is becoming kind of ubiquitous. Most of us are using it every day, and for young people, this has certainly been the case, and they've particularly grown up with social media, which makes them a particularly interesting cohort of people. And certainly people have been questioning and quite interested in to what extent this kind of increased use of social media is playing a part in this increase in mental health problems among young people that we're seeing. Particularly this has been reflected in media stories, which I'm sure you've seen many of, and some examples on the screen, but also in policy and things like the online safety bill. Clinicians in a lot of research have been also reporting more and more concern around the impacts of social media use for certain mental health conditions. And young people and parents and teachers themselves are also really, really concerned about this issue and how best to kind of manage social media use. But what do we know kind of from the academic literature about this relationship between social media use and mental health? Well, perhaps not as much as we would like. So it's not always negative. We are finding some positive associations between social media use and mental health for some groups of people. Can be quite helpful in creating better connections between people and reducing loneliness. But it also, there's definitely been a lot of cross-sectional studies that have shown some negative relationships and a link with depression and anxiety in particular, which cause concern. However, we don't really have too much longitudinal evidence that is slightly more robust to be able to really understand in greater detail what this kind of causal mechanisms of this relationship between social media use and mental health might be. We also don't know much about kind of these moderating and mediated factors that might explain why it's worse for some groups than others or some people than others, and what factors might explain some of that relationship. So it's a little bit complex and murky at the minute. But still the concern about social media use and mental health persists, and that's really kind of where this study came from, is a desire to kind of try and understand this problem in a bit more detail, and hopefully by understanding this relationship we can help to improve things like public health interventions or recommendations for social media use, and hope to inform policy and regulations around this issue as well. So the aim of my study was to kind of address some of those gaps that I mentioned earlier. So it's to really understand this longitudinal relationship between social media use and mental health, but also look at the mediating factors that might help to explain some of this relationship. So I particularly focused on self-esteem and social connectedness as mediators in this particular study. The reason I chose these as mediators was for self-esteem. This has quite been widely reported in the literature as being kind of related to social media and mental health, with the idea being that when we engage in some kinds of activities like comparing ourselves to others, or sort of, they call it doom scrolling, for example, when you're kind of going through and browsing endlessly social media posts, this can be have quite a negative impact on our self-esteem, which can in turn help hinder our sort of broader mental health as well. And social connectedness was something I was also interested in, because on the one hand we see that social media can have these a wonderful ability to help us connect with other people, but the extent to which these connections are kind of good quality and are positive relationships and connections might be questionable, and those kind of things could lead to poorer mental health. So we use data from Understanding Society, which I mentioned a little bit at the start of the title, which is a UK longitudinal nationally representative cohort survey that's run every year. And we use data from the youth survey that is conducted as part of that from 2009 to 2019. And so we had just over 3,000 10 to 15-year-olds in the sample that we had. And we selected those that, had data on social media use and mental health at ages, social media use at age 12 to 13 and mental health 2 years later at age 14 or 15, depending on when they took part in the study, as not every question was asked at every wave. So in terms of how do we assess mental health, we use the Strengths and Difficulties Questionnaire Total Difficulty Score, which is quite a valid and reliable survey measure for young people's mental health. For social media use, we only had one question available to us, which had some data on how much time a young person spent on social media on a weekday, which was on a Likert scale ranging from none to 7 or more hours. And the mediators of self-esteem was measured on an 8-question survey, and social connectedness was measured looking at 2 questions about how many close friends they had and sort of how they felt about the closeness of those relationships. And we included covariates in all our models, and this included the usual things like sex, ethnicity, the year they participated in the study, mental health at baseline, and household income data as well, like household income data and education of parent, for example. And to analyze the data, we did some linear regressions, and we looked at whether social media use at age 12 or 13 predict mental health problems at age 14 or 15. For the mediation analysis, we did some path analysis where we used structural equation modeling, and multiple imputation was undertaken, and all the analysis was run again as a kind of sensitivity analysis. So the results, well, after adjusting for covariates, we didn't find a significant linear trend showing that more time spent on social media was related to poorer mental health. This relationship was significant in unadjusted data, but after we'd adjusted for the covariants, the relationship seemed to kind of attenuate. Things like poorer mental health at baseline and taking part in the survey later seem to account for most of that relationship. And the same results were really found in the imputed sample as well. In the mediation analysis, when we looked to see whether kind of social media was associated with self-esteem, we did find some indication that self-esteem was a significant mediator. So, using more social media was associated with poorer self-esteem, which in turn was associated with poorer mental health. And about 68% of the effect of social media on mental health 2 years later was mediated by self-esteem. But again, this relationship was actually attenuated once we adjusted for the covariates. thought it might have just been interesting to show you some of this original data. But again, the relationship wasn't significant in the imputed data, and we didn't find any significance of the other mediator, which was social connectedness, in unadjusted or adjusted analysis. So I thought it's important to mention some of the limitations of this research, and also the general problems we're having with kind of this social media related research generally as well. And one of them is about measurement, and this is the main issue really. Partly because a lot of these measures about sort of how long you're spending on social media and what you're doing are often very much self-reported, which is obviously not always really that accurate. And a lot of people aren't really exactly aware of how long they're spending on social media. So it could be that we're not looking at this in exactly the best way, and it might be more about how you use social media and whether you're maybe more active on it. Like messaging might be better than being more passive, and a lot of new research is exploring that. And of course, we looked at only quite a specific age window here, so it may not be so generalizable. But to conclude, this study suggests that there is not much evidence of a longitudinal relationship between UK adolescents' time spent on social media and mental health problems 2 years later, although there could be that if we looked at social media in a different way, we would find a different kind of relationship, but it's limited by how we're currently measuring it. In terms of implications for policy and practice, it does seem that maybe just focusing on advice like reducing time spent on social media itself might not be the best kind of advice, and we should think about the role of things like self-esteem and maybe how people are using it actively or passively when we're thinking about developing public health interventions and guidance around this. But thank you very much. That's the end of my talk. Thank you.
Thank you very much, Ruth. That was a fabulous talk, beautifully to time. So we have a question from Angel Chen. Is there information on what types of social media young people were using? You know, whether it's WhatsApp or TikTok? And if not, what would you ask?
Yeah, I think there is some general data on this. Obviously, social media companies are particularly interested in this question as well, about what kind of things people are using. And definitely for the younger age group in adolescence, it is more Snapchat and TikTok, I think, are probably the leading ones. And WhatsApp is definitely as well, but it also varies by country quite a lot. And in recent conversations with some social media companies trying to find out a bit more about this as well, they were telling me that WhatsApp is actually currently being used by young people in quite a formal way, and quite different to how I would use like WhatsApp social media, which would be more informal messaging. But they're moving more towards using direct messaging in Instagram or in other kind of apps through communication, and WhatsApp being more, they said to me, it's being seen more as like email. So it's a very interesting how it's a very evolving landscape, and it's very difficult to keep up to date with. But there are a lot of dashboards that tell you the social media companies are certainly interested in this as well. So it's you have to keep a constant eye on it.
Absolutely. And we cannot assume that what we do, I suspect you're considerably younger than I am, you know, how we use social media is not how today's teenagers use social media. So another question from Capel Sale. If you could have designed the study from scratch, what mental health outcome measures would you have selected?
Oh, interesting. I suppose, well, I was quite satisfied that the Strengths and Difficulties questionnaire was available to me in the Understanding Society dataset, because that is one of the leading measures that you would use for young people's mental health in that particular age group. But I think, you know, yeah, I suppose you would maybe want to think about more specific ones that might be more related specifically to social media. For example, there are outcomes like things like fear of missing out. People have developed lots of different kind of things, and also some social media addiction scales are starting to kind of come up as well. So maybe there could be, in an ideal world, maybe some kind of outcomes like that might have been more specifically useful.
Thank you. And a related question from John DePuri. Was there any consideration of contemporaneous positive effects, such as building community or being able to have a sense of belonging? You looked at psychopathology, a high score on the SEQ is poor mental health, but did you see whether there were any positive effects, so maybe broader in terms of building social networks or feeling more connected?
Yeah, no, not particularly. I definitely think, in terms of none of the social connectedness things seem to be too related, and in a sort of positive or negative way. It does seem, I think there was a sort of it does increase kind of the more connections you have and the more people you know. It didn't seem to make too much of an impact as well on how close you felt with those friends, which was a bit surprising. But again, I think there's probably some measurement issues, that there wasn't that much good measures to really assess kind of that social connectedness feeling potentially as well. So it'd be something I'd like to look into more. So
you've got lots of really interesting questions and I'm sort of dotting backwards and forwards. Apologies to any that we don't get to. One I loved, which is from Rebecca Rowland. Following this research, have you adjusted your social media use in any way?
It's definitely made me more conscious of it, for sure. One of the things I have done a little bit actually is I became a lot more aware of, through reading and stuff, about all the different functions within the apps and within your phone that can help you kind of limit your time spent on social media and limit things that you don't necessarily like seeing, like muting people, doing quiet times on your phone. So I did actually go and do that after doing this, because I thought, although I don't feel like perhaps I use it that much, but I think there's always a temptation to look at it, especially things like before bed, before you're trying to go to sleep and things like that, which is not particularly healthy. So it did encourage me, and I encourage everyone to go and check out their app settings as well.
Okay, and here is a policy related one, which is a really interesting question. So if there is little longitudinal evidence of harms to mental health from social media, do you think that social media companies still have a responsibility to children and young people on the mental health issue? There's no good or bad answer, the person writes, and I totally agree. Just wonder what your personal point of view after doing this research is.
Yeah, really good question. I mean, I think they do, personally, because I think they're, on the whole, I suppose, I think the relationship is just probably very complicated and there are lots of things happening, but I don't think that what the correlational evidence does suggest, and maybe even for particular conditions like eating disorders, self-harm, it could be even more of a particular issue. And I think there is something that people are very concerned about and that they do have to address. And I think it's certainly things around sensitive content and exposing children to, I don't think there could be any really good reason to do that. And I do think that that better kind of regulation and responsibility from the companies is definitely needed there.
Thank you. I think we've run out of time, but thank you, Ruth, for a fabulous presentation, and thank you to the audience for a lot of interesting and very diverse questions. Ruth will try and get through some more, but now we need to move on to our next speaker, who is Dr. Brioney G. So Ruth was from the North Thames ARC, whereas Brioney is from the east of England. She is the development lead for child, families and young people services at Norfolk and Suffolk NHS Foundation Trust. And she's going to be speaking to us about the ongoing implementation project working on worries, and I'll leave you to fill out the details. Brioney, over to you.
Okay, thank you. So I'm really pleased to have the opportunity to talk today about an ongoing implementation project, as Tamsin said, the Working on Worries project, which is being led by the East of England ARC. So the project's all about enhancing collaboration between the health and education systems in Norfolk and Waveney in order to increase access to parent-led CBT for childhood anxiety. So to start with a bit of background about why we thought this project was needed. So anxiety disorders in childhood are common and can have a really significant impact on the quality of life of young people and their families. And we know that they're associated with increased risks of negative outcomes in educational, social and health domains. The good news is that there are evidence-based treatments for childhood anxiety disorders. The issue is with accessibility of those treatments. So a study by Reardon and colleagues reported that of children and young people who identified as meeting diagnostic criteria for an anxiety disorder through school-based screening, only 3% of those children had accessed evidence-based support. And that study by Reardon and colleagues was published in 2020, so based on data before the COVID-19 pandemic. So we know that demand for child and adolescent mental health support in the period following on from the pandemic has only increased, and that's really exacerbated capacity issues within child and adolescent mental health services, where we've got a growing workforce, but still a limited workforce of child and adolescent mental health professionals. So we do really need to think of novel approaches if we are going to be able to provide more young people with access to the treatment that they need in a timely way. The evidence-based treatment that we've been focusing on in the Working on Worries project is parent-led CBT, cognitive behavioural therapy, which was developed by Professor Cathy Creswell and her team. So this approach focuses on the practitioner working not with the child, the young person themselves, but with the child's parent or carer. And the practitioner works with the parent or carer to support them to implement CBT-based strategies in their child's day-to-day life. It's a relatively brief intervention, it's manualised, and importantly for the approach that we're taking in this project, the evidence suggests that the intervention can be delivered successfully by novice therapists. So Cathy's team did some work comparing outcomes from parent-led CBT delivered by therapists who didn't have any previous training in CBT, and compared that to outcomes from clinical psychologists and qualified CBT therapists. And they found the outcomes were very similar. So this intervention, parent-led CBT, was selected by the NIHR Mental Health Implementation Network, who've been working with as one of the interventions that they wanted to target to kind of really speed up the implementation into practice. And this coincided with some work that we've been doing locally in Norfolk and Waveney with the Nebula Federation of Primary Schools. So the Nebula Federation, a group of primary schools in Norfolk and Waveney, and they approached us saying that they really wanted some extra support in their work with their children and their families. So we ran a very small implementation pilot where we worked with them to train up their pastoral team and offer ongoing support and supervision to enable them to deliver parent-led CBT within their schools. I appreciate you probably can't see this slide particularly well. This is an image representing findings from Dr. Tim Clark's implementation fellowship, which focused on this pilot. And we saw some really positive results. So really great outcomes for young people and their families, really positive feedback, and the school staff able to sustain delivery of this approach within their day-to-day work. So the Working on Worries project, or the WOW project for short, is an expansion of that work with the Nebula Federation into primary schools across Norfolk and Waveney. So we were able to secure funding from the Norfolk and Waveney Integrated Care Board to sustain and expand that implementation. And alongside that, we've had funding and support from the Mental Health Implementation Network to think about implementation strategies and evaluate that implementation. So our aims in the project are ultimately to expand access to parent-led CBT for children struggling with anxiety. We're focusing on schools in Norfolk and Waveney with the highest levels of need. And we're using implementation science to optimise our delivery and also evaluating the process and the outcomes of the implementation. How are we going about this implementation? So we started off by identifying practitioners in the local region who are already delivering parent-led CBT as part of their practice. And we offered them further training in order to be able to train school staff to deliver the intervention themselves and provide ongoing support to those school staff members. We then worked with public health colleagues to identify schools in areas of high deprivation or with particularly high levels of mental health needs. And we're also focusing on those not currently covered by a mental health support team. So those schools where the children don't already have access to parent-led CBT through that route. We then approach schools to invite them to participate, focusing on our priority schools. And we ask schools who are interested in taking part to identify an implementation lead who would work with us to implement this approach, and also to identify school staff, so pastoral workers typically within their school, who are already working in a pastoral role to support children and families to be trained to deliver parent-led CBT. We worked with the implementation lead from each school to co-produce a tailored implementation plan that was specific to their school and their context. And then our trainers provided training to the school staff, and also they're facilitating what we're calling collaborative learning and support sessions, or class sessions, which are a way of providing ongoing support to the school staff who've been trained, and also making sure that we're picking up kind of any issues where perhaps young people's needs need some more specialist support, and they can be referred on appropriately. And then our school staff are delivering the intervention. So just to let you know where we're up to at the moment, it is an ongoing project. So it started in January and it's running through till March next year, but we do hope it will be sustained in the longer term as well. So far, we've trained 21 children and young people's mental health professionals as trainers. In our wave 1 of training in March 2023, trainers trained 48 staff from 35 primary schools to deliver the intervention, and they have begun delivery within their schools, which is really exciting. We've just done our wave 2 of training. So in wave 2, we had 39 staff from 27 primary schools, and they'll get going with delivering the intervention from September. And there should be one final wave of training in September. So we're hoping that we'll have at least 100 primary school staff members who have been trained through this project. Also just wanted to highlight the work of our parent and carer advisory group led by Rachel Maguire, who've been instrumental to this project. So this involves some parents and carers who are part of the Nebula Federation pilot, so who had themselves experience of receiving parent-led CBT through their school, and also some parents and carers who hadn't had that previous experience. And yeah, they've been incredibly helpful in making sure that we're implementing this in a way that meets the needs of families. And just to touch on the evaluation, so our evaluation is focusing on implementation, so implementation outcomes and the process of implementation. And we're particularly interested in identifying barriers and facilitators of implementation. And we're hoping that the learning from this evaluation can first and foremost help us to optimise the approach locally and hopefully ensure that it's sustained beyond this initial period, but we're also hoping that we might be able to share our learning nationally with others who might be interested in taking a similar approach. Just to end with some acknowledgements, so to acknowledge my project co-leads, so Dr. Tim Clark, Dr. Bonnie Teague and Dr. John Wilson, Ella Mickleborough is our excellent project coordinator, Luke, our assistant psychologist, Rachel Maguire, our PPI lead, who I've mentioned, and Natalie Brown, who is the pastoral manager at Nebula Federation, who's continued to work with us and has been absolutely key in making sure that we're working in a way that fits with the context of schools. And also to our funders and the much wider team of stakeholders who've been working with us on this. So thank you so much for listening, and I'm happy to take any questions.
Thank you, Brioney. There is a question from Grace Hill saying parent-led CBT is provided in NHSTs, mental health school-based teams across the country. But are you aware if it's offered within other services in the community outside of school?
Yeah. So yes, it is already being provided by MHSTs. So we have, I think I mentioned, been focusing on schools that aren't currently covered by that MHST programme at the moment. And it is also available through some services locally, so CWPs, children's wellbeing practitioners, are often also delivering parent-led CBT. But yeah, we know that access still kind of isn't good enough, and we've been approached by some schools even where they are covered by an MHST, where they've said they really would still like to be trained up in this approach as a school, because even in MHST schools the kind of resources are limited, So their kind of rationale, their thinking is that perhaps if their staff are also trained, then perhaps the MHSD staff could focus on perhaps the young people with slightly more complex difficulties, higher level difficulties, and they might be able to focus more on kind of early intervention.
And of course, we shouldn't forget that the original aspiration was that MHSTs would be across a third of the country. That leaves an awful lot of schools without them.
Yeah.
Okay, lots of excellent questions. Keep them coming in. Roberta Pirodi, excuse me if I mispronounced your name, asks, well, apart from thanking you for a great presentation, Brioney says, how did you identify the schools or locations that had higher mental health needs?
So we relied very much on our public health colleagues there. So we asked them to kind of prioritise the schools that they saw as having the highest level of need. So that wasn't something that we kind of did internally. We kind of handed it over to them, and they came up with a list of 40 schools that they thought we should be targeting based on a combination of the deprivation of the local area and that mental health need. So I could find out a little bit more information from public health about exactly how that prioritising was done. But yeah, we've taken a very kind of collaborative approach throughout. So kind of, yeah, working with colleagues who know the local area and the needs of schools well.
Brilliant. And then Leon Spencer says, it may be too early, but have you been able to identify characteristics that make parents or carers more likely to engage with this kind of intervention?
Yeah, unfortunately, I think it is a little bit too early. So our wave one schools have only just got started with implementation, really. So we don't have data yet that we can explore, but we're really interested in that, particularly thinking about kind of equality and inclusion. We want to make sure that we're not widening health inequalities through this programme, and that is something we're conscious of. So that's the reason that we did specifically try and target schools that might have higher levels of need. But then we are conscious that within that, it might still be that the parents and carers who are able to access the programme are perhaps slightly different to those who aren't. So yeah, no data to answer that question at the moment, unfortunately, but it is something we're really interested in.
Okay, I am seeing a cue to move on. You have generated a lot of interest and a lot of really good questions. Thank you, Brioney, for an absolutely fabulous presentation. Well done.
Thank you.
So we're now on to our last presenter, but certainly not least. That is Dr. Gretchen Bjornstadt. I should be able to say your name without stumbling over it, Gretchen, seeing as we worked in the same place. I do apologise. Gretchen is a senior research fellow in the NIHR Applied Research Centre in the Southwest, affectionately known as PENARC, and she is going to speak to us about questions from how you get questions for research projects from young people. Over to you, Gretchen.
Thank you. Can you see my slides? Okay, yeah, okay. Hello, hi, I'm Gretchen Bjornstadt. The project I'm going to be presenting about we call CAMHS, which stands for Research Inspired by Service Experts. And this is a collaboration with two clinicians in Children and Family Health Devon, the Research and Development team at Devon Partnership NHS Trust, and PENARC and CHIME, the Children and Young People's Mental Health Research Collaboration at the University of Exeter. So this project aims to develop a system or a pathway for new research questions to be generated by CAMHS users, children and adolescent mental health services users, parents and carers and staff, to create a repository of questions that could be used for service evaluation or research projects that are kind of coming from local service users in Devon. We aimed to link with the Declin Psych training program. Clinical psychology trainees do service evaluation projects as part of their training. And so we wanted to connect with those programs to kind of create a pathway for those questions to get to lead the projects conducted by them, as well as other researchers as well. So the project began because a young person who was involved with the Devon CAMHS participation group asked whether there was a correlation between the time spent on CAMHS waiting lists and length of subsequent treatment in CAMHS. And this question was sent over to the CAMHS, the Devon CAMHS Research Board, who realized that there was a need for a system to enable children and young people to share their questions that could potentially lead to projects. So a team from Devon Partnership Trust and the CAMHS team and CHIME and PENARC applied for funding from the Southwest Clinical Research Network Innovation Fund for the CAMHS RISE project, which funded us for the first 6 months. And then the PENARC Mental Health Research Initiative provided an extension to carry on for another 6 months. So for this project, we wanted to generate research questions. We thought we'd use a workshop kind of involvement method based on other previous involvement work that we'd done in PENARC, as well as inspiration from other question priority setting programs such as the James Lind Alliance. So we kind of developed an idea for the workshops and how we might want them to go. And then we met with local youth group leads around Devon from the CAMHS participation group, the Young Devon, which is a charity that offers several youth groups around Devon, and Devon County Council, who run Devon Youth Council, to ask them how they were running groups with young people, particularly because we were coming out of the pandemic. So we needed to learn about, would these be work best online or in person, or, how are you getting young people together at the moment? And just also kind of to run through our ideas and what we thought would work and ask them for their feedback based on their work with their young people. So we revised our plan based on that conversation. And then we were lucky enough to meet with a group of 8 young people with CAMHS experience to talk about what we wanted to do and show them our ideas for the workshop and get their feedback. And they really helped to shape our workshops. They gave us some brilliant ideas. They were very, very interested, very keen and vocal. And they even provided us a hand-drawn icebreaker activity that we were able to use, which was brilliant. So we developed these workshops. We ended up running 3 workshops with young people and 1 with parent carers. They were done in different ways, Zoom and Teams and face-to-face, depending on what worked best for that group. And we also created an online form to enable people to submit anonymous contributions outside of the workshops, either after taking part or separately if they couldn't join the workshops. And that was also sent around to clinicians if they wanted to send us any ideas for research questions. So the workshops themselves, this is kind of the outline that we followed to run those. They were very flexible and they really kind of were responsive to what the young people wanted to do, but this is kind of the outline that we followed. So we introduced everyone, we did the icebreaker, which is this lovely drawing. We also talked through some ground rules around confidentiality and no pressure to share any experiences or thoughts if you don't want to. We talked about what research is and how public involvement can shape and influence research, and how research can then potentially lead to changes in service. But we also talked about where research questions sit in the research process and how long that whole process can take. So kind of manage expectations a little bit and talk about how that works. And we talked about this CAMHS RISE project and what we were hoping to do. And then really, of course, the most important part of the workshops was to listen to young people's ideas, which usually involved them talking about their experiences in CAMHS, what they felt worked well, what didn't go so well, and what ideas they had for things we might want to look into and research to improve things. And that, led to a discussion where they often were building on each other's ideas, which was, brilliant to see. Everyone was very, supportive and really, really keen to have this conversation. And then myself and a clinical colleague were kind of co-leading these with the group facilitators supporting. And we often, we kind of ask clarification questions and just to check our understanding and to find out a bit more and to kind of shape the questions, the ideas into research questions. And then we talked with the young people about what the next steps of the project were going to be, which was to prioritize the questions, which we did. We did prioritization using an online survey, which actually we did several iterations of as we went along, because we wanted to write evidence summaries of some of the top ranked questions, which we'll get to in a moment. And so in order to get that done within the timeline of a fairly short project, we kind of did it as we went. So the prioritization kind of developed as we went along. We also asked parents to prioritize questions. They actually chose the same top question as the young people, but went with our second one so that we could write an evidence summary for one of their questions. And then we ended with 106 questions, which we ran through a final prioritization. And our top questions, and we had seven top questions. That's just because that's the number of evidence summaries that we were able to write based on the prioritization from the young people and their parents. The questions were, I'm not going to read through them all, but I will share them here in after, but they generally were around things around the waiting lists, parental support, what can be done to help young people feel more listened to, CAMHS treatment for ethnic minority children, having a diagnosis of a neurodiverse condition, and strategies for improving transition from child to adult mental health services. For those 7 questions, we wanted to develop these evidence summaries for those questions, and that was primarily to give something back to the young people and families who took part in the project, but also to sort of share what is known at the moment with the general public on these questions that were prioritized in these groups. So to do these evidence summaries, we did a rapid search of the highest quality evidence. It was very rapid, it wasn't a systematic review, but our evidence synthesis team at PenArc searched for the evidence for us, and then we drafted plain language summaries of the existing evidence for each question. And then after doing that, we asked an expert on each particular topic to review our draft to see if it kind of married with what they understood to be the state of the evidence for that question, and to find out about any ongoing studies. We then revised the summaries and then asked a couple of young people and a clinician to review them to check that they were kind of relevant and answer the question as from their perspective and were easy to understand. And then we did our final edits, and then we shared those evidence summaries with the young people and the parents who took part in our groups, and they're also available on this website, and you can access this via the PenArc website as well. The first 6 are available. The 7th is on the way. It's nearly done, but they're up there. The first page is a kind of an overview, and then there's more detail about how we did it and what we found and what the gaps are, what needs to be done next. Just to think I can share what's known about the 7 questions. And then next we're sharing this project, but we've drafted a process notes about how we did the project, so that within Devon we can run this project again in future years to kind of refresh the questions. We're also working with at least one other trust who's interested in thinking about replicating the process in their area. We're writing a paper at the moment, and we're working with the Declin Psych programs at Plymouth and Exeter to develop a system for sharing the research questions for service evaluation projects. And that's all. Thank you.
Completely fantastic. So, question from Liam Spencer. PPIE is often criticised for being tokenistic. What do you think the best way to overcome this is, and to ensure that it's meaningful and children and young person led?
So yes, I think well, yeah, I mean, one of the ideas about doing this project is, it's rather than coming up with a research question, kind of sitting in our offices in our university and then just getting a little bit of input from young people, we actually wanted to ask them from the beginning, where should we start? But we didn't lead that in any way. It was really just trying to listen and reflect and ensure we understood what they were saying, but just take those down, really, those questions. So I guess that's one important part of it. But I also, we did try to, talk with them with some young people beforehand to say, this is what we're thinking about doing, what do you think? And kind of get them to help us shape it to ensure that what we were doing is right. But I think the other thing is to kind of feedback as well to the young people, or to the members of the public who are taking part in being involved in research. So which partly was the purpose of the evidence summaries, I guess, was to kind of give something back. This is, these are the questions you said were most important, and this is what we know about them so far. But and what we do, we have still kept the list of the young people who have taken part, and we're very much hoping to stay connected with the Declin Psych programs so that we know which questions are being taken up so that we can feed that back to the young people and offer them the opportunity to be involved in those projects if they do go forward. So I think it's just, yeah, it's about, I guess, listening and really, genuinely taking on board what people are saying and not sort of just pushing your own ideas out there and just taking notes on, it's really kind of collaborative and changing what you're doing based on what's said, but then also importantly, kind of feeding back to the young people.
I think the feeding back often gets forgotten. And I think actually this is a lovely example where even before you started getting young people to help you prioritize, you were consulting them about, are we doing this right? And I think, the more you do PPIE, the more essential you realize it is, whatever kind of research you do. And if it is done in a tokenistic way, you are going to get less out of it. I think you'll also struggle to get people to work alongside you. Okay, another question for you. You've talked a little bit about the questions that you've prioritized. The higher list questions are going through to the declin site, which I think is inspired because they need experience, and I'm sure they would rather be studying questions that are important to people. Will any of them be developed further for primary research studies beyond the declin psych?
Well, yeah, we hope so. We're still, yes, we're working on that. So one of the things that we've tried to do is to kind of categorize the questions. So one thing we did have to do was take some of the questions were really just kind of almost like frequently asked question, kind of things that could just be answered by the CAMHS program. And so that are the CAMHS service. And as it happens, the CAMHS team are revising their website at the moment. So they've taken those questions kind of out of the list, and they're trying to ensure that they're answered on their new website so that it's information that obviously wasn't available that needs to be available. And then we're trying to kind of look at the questions in terms of which ones would make good service evaluation projects and which are bigger questions that need larger kind of research and to kind of create a list like that. But one of the things we're not quite sure about how to do is how to share that list then with other researchers who, outside of CHIME, who might be interested in looking at that. So yeah, be interested in feedback, or if anyone wants to ask me to share that, I'm happy to.
Last question, which is, how did you facilitate the involvement of young people in the study? How did you get to them? Because that's often the first hurdle for people.
Yeah, I think partly because of the situation we were in terms of the pandemic at the time, but also to sort of ensure that we are properly safeguarding the young people and supporting them as much as possible. We worked with existing groups of young people. So rather than creating a bespoke PPI group for this project, we went out to existing groups. So that was we met with the CAMHS participation group, a wellbeing cafe that's being run in Devon, and a kind of support group for care experienced young people that's already running, and we fit in with them and how they work. So so we went to them, or we met with them online, or they allowed it, depending on what they wanted. Sometimes they allowed us to just come in for part of their existing session or set up a separate session. And so the facilitator of those groups was also with us in the session. So they were there for support and to ensure everything was run as the young people wanted. They would kind of tell us, this is what we normally do at the beginning, so that we would kind of follow a similar process to what the young people were used to, but then we sort of ran our piece of it. So that was kind of how we I guess got to the young people, but also that's how we supported them as well. Yeah,
brilliant. What a fabulous series of talks we've had. So thank you to Gretchen, to Brioney, and to Ruth, and thank you to the NIHR ARC network for hosting us, and thank you for giving up your lunchtime to come and listen to these presentations. Thank you.